started. Good morning, good afternoon, good evening to anyone who is online. I'm Lindsay Denny-Naughton. I'm a WaSH program specialist at UNICEF, and my portfolio focuses on WaSH and healthcare facilities at the headquarter office. Glad to welcome you all to day 2 of the conference. If this is your first day, welcome to the conference. We are having a special track on WaSH and healthcare facilities at this year's conference. There was a session yesterday. Today is the second session, and we'll be focusing on 2 broad approaches to WaSH and healthcare facilities. The first is WaSH Fit, the WaSH Facility Improvement Tool, and the second is the 8 Practical Steps, which looks at system strengthening for WaSH and healthcare facilities. We have an exciting agenda today. We're going to have some scene setting from the illustrious Bruce Gordon, head of the WaSH unit at WHO. We'll talk about some findings from 2 recent reports on those 2 approaches I mentioned. So we'll look at findings from progress on WaSH Fit in using countries, as well as the recent Global Progress Report on the 8 Practical Steps. We have some case studies to share from colleagues working across the world from Save the Children, PATH, and Terre des Hommes. And then we'll hear about the community practice on WaSH and healthcare facilities. So very excited to get started. Bruce, I'm going to invite you up to start us.
Thanks, Lindsay. Well, I guess it's my job to say welcome. And I'm going to go off a bit of script here, Lindsay, because we're a small group and it's what I do. But no, just reflecting, I was talking to Ryan just in the corner there, and it struck me how long we've been working on this issue. I mean, maybe some of you have come to this recently in the last few years, but the amount of, I guess, time that various partners, and I'm very happy that all of you are here today, have talked about this, have done work on the ground. From the halls of the UN General Assembly, to the World Health Assembly itself, like we've been working on this tremendously. And so one of the things that's consistently come up is just the real kind of credibility of the tool WaSH Fit. Maybe I'll start with that, because I think there's been a lot of feedback that we've got from member states from a policy perspective, where they've talked about WaSH Fit, and on the one hand, it's a tool, it's a sort of a risk management, continuous improvement tool, but it's actually driven a lot of awareness, because it, thanks to a lot of your efforts, it's really brought, stakeholders together at country level, and it has that really nice kind of balance between doing real facility improvements and driving a policy environment, which has been really, I think, incredibly important. So we know that more than 70 countries have taken on and done WaSH Fit, which is, it's a bit overwhelming for me. We know that 100 countries are now reporting and reacting to the 8 practical steps. And hopefully you've all seen the last progress report that WHO and UNICEF put out on that, where there's some analysis, and Real and Lindsay and others will be talking about some of the efforts that we've seen. And a lot of them, I think, are really compelling, in the sense that many countries, especially some of the low-income countries, have essentially done most of the practical steps, or a good chunk of them. And then I guess the promise on our side, the collective global community, is to help those countries realize, their vision, right? We also know that when we look at some of these costed roadmaps, which take a long time to do, and I've personally spoke with a number of country policymakers that have put together roadmaps and put costs against them. They're sort of like, well, we do this and we've done it continuously, but where's some of the funding? So that kind of just leads me to this kind of honest, and a reflection of where we are, right? Because we heard in the plenaries yesterday, and we all know that we're at, international global health is at a very interesting time. Development is at an interesting time. And this particular agenda is at a very interesting time, because we just had a report back, a really nice session led by Hungary and the Philippines at the UN General Assembly, the UN General Assembly. It's funny, that's where it was, a side event. And really kind of took stock on this, and I think that there was a ton of interest. I was at a regional meeting with the Pan-European region, and they also went through all the 8 practical steps. And we know this is happening in different forms all over the world, and it's happening here. So I think it's just to kind of remind people that we have a long way to go. We should be focusing on, I think, fragile countries. We know that 19% of them, I have a figure here, have basic sanitation only. And so, and less than 40% have basic water. And few of them have the costed plan. So I think there's a lot of work to do. But I do want to kind of just welcome, I think, most of all, the practical experiences that all of them will share. Because I think it's at this point where I think we've put a lot on the table as far as intellectual kind of ideas, insights, reflections. And it's, I think, the case studies that we're going to see today, I'm really interested in hearing from them so that we can kind of try to pursue together some of the opportunities to make change. So with that, thanks very much for being here. And I'm going to pass it back to you, Lindsay.
Thank you very much, Bruce. We're going to be interactive here for a second. Quick show of hands. How many of you are familiar with WaSH Fit? Okay, great. Like you said, it's been quite overwhelming how many countries are using it. How many of you are familiar with the 8 practical steps? Okay, a little less so? Great. Well, we're going to go through that briefly. I'm going to do a little wizardry here. Maggie Montgomery, can you hear me?
I can hear you. Can you hear me?
Wonderful. Yes, we can. We have Dr. Maggie Montgomery with us, Technical Officer at WHO, calling in from Geneva. Maggie, could you kick us off and we'll talk about the new progress report on WaSH waste and electricity and healthcare facilities.
Certainly. Thank you, Lindsay. So hopefully, as you all are aware, we did launch the latest Global Progress Report in September. It was in association with a high-level event, the first we had hosted on this issue by Hungary and Philippines at the UN General Assembly. And, the overall aim is to provide the status of progress towards not only universal access, but some very specific targets that are included in the UN General Assembly resolution from 2023. We also have the World Health Assembly resolution, and we have targets that are outlined in the global roadmap. We had a significant increase in countries responding, which really enthused us because we saw it as a sign that countries are more and more engaging in some of the key national actions. So we have data from over 101 countries. And just very quickly on the data validation, you can read more details in the report that what happens is countries, and it's usually the Ministry of Health with support from partners, including WHO and UNICEF and other NGOs, fill out a survey kind of saying where they are on certain things around standards, around monitoring. WHO and UNICEF then ranks them on a 4-point scale, and then this is once again validated. For the first time as well, we've really tried to link the resources that countries have provided to give evidence for where they are on our global tracker site. So if you're curious about certain countries, and Bruce was mentioning roadmaps, we have 14 roadmaps, for example, costed roadmaps that countries have developed. Please go have a look there. Next slide. We've always tried to be really clear about the case. Why do we need better water, sanitation, waste, and electricity services in healthcare facilities? There's more reason than ever. And we have obviously the need to make sure that these services are safe and climate resilient and environmentally sustainable. And this has a lot of resonance, not just in countries that are lacking access, but even countries, middle and high income countries, have a lot of work to do to make sure they improve the resilience and the sustainability, especially around, for example, issues on reducing waste, the type of waste. It's obviously a foundation for quality care, and with the new focus on providing universal health coverage through the primary health care network, where we're seeing a lot of these smaller facilities have even worse access than hospitals, this issue becomes even more important. I'm not going to go through the whole list. You can see it there. But I also just wanted to highlight here, this graph shows the economic gains from investing in particular elements of our agenda. And you can see for environmental hygiene, so this is cleaning, for every $1, there's a $5 gain. And for hand hygiene in healthcare facilities, there is almost a $25 economic gain. This comes from the IPC investment case. So there is a huge economic incentive to make sure that these services and the associated practices are in place. Next slide. So where are we in terms of the progress? This table here lists the different actions looking at policy and governance. You can see where we were in 2022, which is the baseline, where we are this year, what the targets are looking ahead. So for certain elements around countries defining what is their baseline service, we've made a lot of progress and we're actually on target. National standards is not doing quite as well, but still we've seen there's been a lot of progress to strengthen waste standards, to look at very specific things, for example, around pharmaceutical waste or removing mercury from healthcare systems. If we go further down the list, we can see that we're further behind in terms of costed roadmaps with dedicated resourcing, national coordination, which is super critical given that this issue often falls between several sectors. And if we go all the way to the bottom at sufficient financing, we can see we're only at 17%. So there's a huge gap there. And this was something that Bruce also mentioned at the beginning. Next slide. This is summarizing the JMP data that came out last year. Again, you can see that we're off target for all the areas. Water is probably the closest at 78% in 2025 and a target of 80%, though we know that water indicator is very basic and isn't looking at issues around quantity of water or quality of water. The LCDs are significantly further behind, and certainly we recognize that this needs to be a priority to make sure that facilities without any access or with below basic are getting support and resources to increase access, in particular because these countries are often dealing with outbreaks such as cholera or in humanitarian emergencies. Next slide. I've already mentioned this, but the gaps in services also indicate large inequities. And if you look at this figure 7, you can see the difference in access for water, sanitation, hygiene, and waste management between hospitals and non-hospitals. Now, the majority of facilities in most countries are actually these non-hospital primary care facilities. And, the gap can be more than 20%, for example, for water. So this is something that also urgently needs to be addressed. Next slide. The good news is that countries are taking action. And, we found that of the 101 countries, 82 have fully implemented. So this is that, they've developed standards, they've, put them through the legislation, that they're starting to implement and actually regulate some standards. So that was super encouraging. We had 17% of countries who have substantially advanced or completed all the national actions. And these national actions are what we were calling the practical steps to make sure that at the national level, those systems and policies are in place to support better services. So a few I've already mentioned, like baseline assessments, WaSH and waste standards, we see that those are quite well implemented. And if you can look at this figure 8, you can see green is where the number of countries that have fully implemented the action, yellow less so, and then all the way up to red where action hasn't been started. The least, as I've already mentioned, are the roadmaps, also infrastructure improvements. And these are really linked to financing as well, because in order to make those consistent improvements that require both the CapEx and the OpEx, there needs to be a regular budget and regular financing. As well as workforce. And we're very aware that we need to make sure we have trained, well-paid and supported workforce, especially those that are not necessarily providing care, but doing the cleaning, doing the waste management. Next slide. Okay, again, this is just another way to show kind of where progress is greatest and where progress is least. Again, I would encourage you to take a look at the report if you want to go into more details. Slide. We did take a special look in this report for the first time to try to understand, okay, how does the overall score, so in terms of implementing all the national actions, compare to the actual coverage? And this is just an example from basic hand hygiene services. So this is having either soap and water or alcohol-based hand rub at the point of care, as well as near the toilets, versus what countries have done in terms of standards, monitoring, investments. And this upper left quadrant, you can see these are countries that have taken a lot of national actions, but still have quite low coverage. So potentially these countries are ready to implement, but they need some kickstarting or some leveraging in terms of the financing to make some of those national actions into reality. Many of these obviously are least developed countries. Next slide. We also increasingly are working to integrate and bring together our efforts with the electrification efforts. There's obviously some clear linkages with pumping water, with chlorine generation, with heating water, but there's kind of that bigger overall element that facilities are looking at their overall infrastructure package, and energy is part of that. We did find again that countries are making some efforts to advance electrification in terms of baseline costed roadmaps and monitoring, but there's still a lot of gaps. There's more red, which is no, countries haven't done this, versus blue. So moving forward, certainly it is advantageous for us to think about how we can better align policies, how we can co-locate investments, and try to make sure that we're not coming in with separate infrastructure packages. Next slide. Okay, I'm going to hand it over to Lindsay now, who's going to highlight one specific practical step about infrastructure improvements that we've supported through WaSH Fit. So over to Lindsay.
Thank you so much, Maggie. Great. So, all right. So, Maggie mentioned this report. There are copies as you walk out. If you'd like the executive summary, please make it so I don't have to bring them on the plane. Take one with you, and you can dive into all the data she just mentioned. So in addition to doing the recent Global Progress Report on the 8 steps or national actions, as Maggie mentioned, we also did a recent review of WaSH Fit to look at how the tool is being implemented across the world. And for those of you who aren't familiar, WaSH Fit is a risk-based management approach that looks at improving water, sanitation, hygiene, waste management, environmental cleaning within the healthcare facility. It's a 5-step process that follows the simple cycle of building a team, assessing the facility, identifying and prioritizing needs, making improvements, and then actually monitoring and evaluate the process. It's been used, as Bruce mentioned, in over 70 countries, which if you've been following along in this process of WaSH in healthcare facilities, phenomenal to see just how much there's been uptake of this. But that speaks to what does that uptake look like? Oh, good. All right. So we undertook this review at the end of last year, and we had countries submit surveys to tell us about how they were utilizing the tool. We found that the use of WaSH Fit has steadily increased since it was first launched in 2015. So you all are aware there's an updated version that was released in 2022 that has more focus on gender equity and climate, but it was first launched in 2015. And it's being used in a number of diverse settings. It's been adapted for use in larger healthcare facilities and hospitals, as well as in conflict and outbreak settings. It's been used in middle-income contexts as well. Users have noted multiple benefits to using the tool, and I'll actually break that down further shortly, but this incremental approach to improving WaSH services has been found to not only increase WaSH access, but also other elements of the facility. They found that WaSH Fit provides data and a framework for supporting health system strengthening, especially around monitoring health workforce and delivering quality care. Governments have been actively involved. I think that was really critical to this conversation. Back in 2015, 2016, this may have been more project-based, but really this is growing to be, as Maggie was talking about in the 8 steps, we're looking at more national level programs. National trainings have created capacity for implementation and engagement of stakeholders, but of course, as we come back to, funding is one of the biggest challenges here, particularly thinking about sustainability of the program beyond just the initial project implementation. So I mentioned some benefits, perceived benefits. So we didn't go and measure this. This was what the respondents told us. And sorry, this is so small, but there's sections on budgeting and financing, operations and maintenance, institutional changes, patient and staff satisfaction, and service provision. And 65% reported that WaSH helps support operations and maintenance, which of course we know is critical for sustainability. 50% reported improved staff satisfaction, and 60% reported improved patient satisfaction. We're going to have conversations later this week about the alternative benefits to WaSH in healthcare facilities, but certainly patient and staff satisfaction is critical to, one, maintaining staff at the healthcare facility, and also ensuring that you have users coming and utilizing these services. And then 80% reported that using WaSH unsurprisingly improved their WaSH services, which is fantastic. So overall, very pleased to see that this tool was being utilized, and there were benefits found from implementation. This was very hard for us to conceptualize, but in short, what we wanted to demonstrate is that while WaSH is a step of the 8 practical steps, you can actually utilize WaSH throughout the 8-step cycle. And so I've only shown 4 steps here, but essentially you can use WaSH to then the practical steps to identify where you might want to implement WaSH. Alternatively, when you're using WaSH it can inform future analyses of the situation in the country. For example, for standards, you can recommend the use of WaSH through your national standards. Meanwhile, it can guide facility improvement when you go from WaSH into the practical step process. So these things are very interlinked. They're not necessarily meant to be standalone tools. We can start integrating them. A couple of examples. So Maggie's done a lot of work in Ukraine. We've been applying particularly WaSH to strengthen waste services. And this is pulled from a study that Maggie and team have recently published. After 6 months, the average WaSH score improved by 18 points, which is massive here. And the improvements were greatest in healthcare waste and in hand hygiene. The lessons learned here that conducting the assessments with the team identify these hidden issues. So it's all fine and good to talk about this, but when you actually walk around the facility and have the facility identify their own issues, it can really bring to light some of these things. Small improvements can catalyze larger ones, and that health facility standards and on-site mentoring facilitates improvements. Similarly, in the Philippines, there's been a really strong focus on climate resilience. So they were one of the first countries to develop their own WaSH standards, and they're aligned with their national green and safe healthcare facility standards. They've utilized the tool in over 500 healthcare facilities, and they actually do a process of rewarding top performers, which is common. We see this throughout a number of people utilizing the tools. And then the data is actually being brought back. They've developed a digital reporting platform so that the WaSH assessments are feeding back into the national system, which I think is critical in terms of long-term improvements. Just to circle back, we wanted to make sure we, connect this back between the 8 steps. So a couple of countries here, we mentioned roadmaps are critical. So in addition to looking at the WaSH we're looking at roadmaps as part of the 8 steps. And there's 2 countries that have done really impressive work of recent, Ethiopia and Indonesia. In Ethiopia, their recent costed roadmap aligns with their health sector strengthening plans and is costed over 10 years. With the greatest portion unsurprisingly needed for climate resilient infrastructure. And what I think is, and actually this is true for both, they've broken down who will provide the finances. So in Ethiopia, half will be leveraged from federal and regional governments, and the remainder coming from development partners and local governments. Similarly, Indonesia has a roadmap that ends in 2030, focused on the primary healthcare facilities, and they have a strong focus on inclusivity and gender throughout. They said the amount of funding would be needed for 500 million to address these primary healthcare facilities, and 75% to be leveraged by the government, 25% by partners. So again, really critical to start, as we start doing this process of not only understanding what the needs are, but developing that into a plan that partners can then come and invest in. So one final slide here. I don't know what happened in the top corner. But before we open up to some case studies, I wanted to share one case study from UNICEF. We are currently undergoing a program supported by the Republic of Korea. It is the largest WaSH health program we've ever had globally, and it's focused on system strengthening. There are 3 pillars in this program: immunization, primary health care, and health facility infrastructure. And within health facility infrastructure is WaSH and oxygen. I make this point because this is not a WaSH and healthcare facilities program. It's a health system strengthening program, global health security. And yet we've managed to have about half the budget focused on WaSH and healthcare facilities. And so, as we'll hear from other partners talking about their programs in a second, I think there's a theme here to how we think about supporting WaSH and healthcare facilities. It's a 35-country grant. We got about 50 million over 2 years. Approximately 18 million of that has gone to WaSH and healthcare facilities, and it ends in December 2025 with hopefully a 3rd-year renewal. We've had some impressive initial outputs. More than 500 healthcare facilities have been equipped with WaSH. Nearly 15,000 health workers have been trained on infection prevention control and WaSH Fit. But actually what I think is more interesting is the work that was done on the practical steps. So this is a number of countries that have supported the efforts, not to say that they've necessarily met that green line that Maggie was showing earlier. But if you look across the first 6 steps that we monitored in the progress report, 13 countries are helping support the national governments do situation analyses or baselines. 16 are supporting costed roadmaps. 8 are working on guidelines. Nearly all the countries are doing infrastructure improvements. 13 are helping integrate monitoring indicators, and 31 countries are helping develop the health workforce. And what I want to make the point here is that if you do the math here, 18 million divided by 35 countries, it's not a ton of money per country. And if you've ever done a healthcare facility improvement program, you know that it's not cheap to improve a healthcare facility. But you can do a lot with not a ton. The work on system strengthening is so critical, and it doesn't take a ton of funding to help move us down from being in the red, the orange, to the yellow, to that green space that we're looking at. So I strongly encourage all of you, as we think about the work that we're doing on WaSH and healthcare facilities, to not exclusively look at WaSH Fit, but how do we integrate the 8 steps as part of that process. And with that, I will pause to see if we have any questions before we look at some case studies. And you can stop hearing my voice.
Is there a database or somewhere on your WaSH Fit website that has all of those national standards you say that have been developed based on?
It's almost like you lined up a question that we needed. Yes, absolutely. So if you go to washandhcf.org, there is a specific section / country tracker. There is a section there that will have the 8 steps and the actual tracking, and it links anytime we have the physical document, we've uploaded it. So when I talk about these roadmaps, those should be linked under the country, under Ethiopia. If you look at costed roadmap, I've linked the document. You can also go to the resources and just Google under our resources section on washandhcf.org. You can look up and look up Ethiopia and see all the documents that they have uploaded.
Thanks.
Any other questions?
Yeah.
I should put you on the microphone, sorry.
Thank you, Lindsay, and thank you, Maggie, for these presentations. It's been really interesting as a informed layperson trying to get my head around this. I'm Nat Painter. I work at UNICEF. But looking at the progress on the 8 steps, I was trying to understand if there is, it seems, I'm going to say all over the place on the progress. And so I'm wondering if is there one step that a country should focus its efforts on, or is there one particular step that might unlock other steps after that, like a key step where a country might focus their efforts, since doing all 8 seems to be a challenge for many countries?
Maggie, you with us? Do you want to take this one?
Sure. Yeah. Thank you, Nat. That's a really great question. And it's something we've obviously thought about. There is no formula for this. And you're right. While maybe it looks like things are all over the place, if you kind of look at where the green bars are the highest, we can see that on the technical side, countries have done what they can, right? So the standards, the baselines, um, even some kind of progress on some of the situational analysis where we see that it's a lot, and those things are fundamental. Like, for example, in the Ukraine WaSH Fit work, like a huge motivator to put in place WaSH Fit and to do those incremental improvements was because Ukraine had recently updated their healthcare waste standards to be in line with the EU, to look at segregation and recycling and non-burn technologies versus the old Soviet system of just chlorinating everything. But like, those regulations were an important kind of stick and carrot to get them to implement incremental improvements. So yeah, those technical things are very much important. Where we're seeing that we need to unlock more and really invest more energy and resources is on the financing side, on these costed roadmaps, which obviously need to be part of a bigger WaSH and health planning cycle, right? And needs to also align with the fiscal realities of countries now, which has changed quite a bit, as Bruce mentioned. So I'll stop there. I don't know if Lindsay has something else to add.
Thanks, Maggie. No, I think that was great. I don't like watching myself here. I think that the costed roadmaps are ones that we're really focused on supporting countries. But to Maggie's point, it's hard to do a costed roadmap if you haven't done an assessment. So at the very least, an assessment and situation analysis would be the bare minimum of what we need to understand. In Cambodia, I mentioned the Republic of Korea grant, they used the first part to do the full national assessment. They'd never done one. And then that fed into the process to build their costed roadmap. So some of these are interlinked. I will say a lot of them, even though here, we might see the numbers here are low in terms of workforce and development and infrastructure improvement. It's not to say that there isn't project-based efforts happening. That green is indicating if you have a national, sustainable system to improve healthcare facilities. And that's where we really aren't seeing, countries you might be doing a small number of facilities, but it's really not a widespread initiative. We have a question in the chat. I'm going to transition to online here for a second. That's been asked by Josh Glasser, saying, many countries are working hard to train and retrain health workers. It's not surprising that so many facilities doing WaSH Fit have seen improvements in worker satisfaction. How is this measured, and how is the messaging to Ministry of Health leaders? I think it's a fantastic question, and actually links back to a verbal presentation that was yesterday. If you didn't catch it, there's a postdoc fellow, Lucy, from UNC, who has put together a tool to monitor, to measure worker satisfaction and patient satisfaction. Am I saying this right, guys? Of the WaSH improvements at the healthcare facility. And so what we did for the WaSH Fit was just perceived benefits. We didn't actually measure here, but I do think a tool that actually is able to capture that and be fed back to decision makers to say, this is why it's important. It's not just WaSH. It's going to help support, patient satisfaction, staff satisfaction is going to be critical. Any other questions? Yeah, Adam.
Thanks, Lindsay and Maggie. I'm wondering if you all can have a little bit of reflection after 10 years with WaSH Fit coming on, and thinking about how WaSH in healthcare facilities is being framed. How have those discussions with ministries of health changed over the years? Given that we're now seeing that it's a climate-related topic. It's now with immunization, it's now with PHC, and looking at these scores and how they changed over time. I'm just curious, in that reflective nature, how have those conversations changed?
Bruce or Maggie, do you want to jump in on this?
I'm happy just to give a quick reflection. I think that you've nailed, already part of the answer, that we're seeing it done not to necessarily improve WaSH. Obviously, that's an intermediate outcome, but to contribute to a broader program, right? Probably the area where we've seen the most integration is with the IPCAF tool, the IPC. And, you know, as there's been much more attention given to IPC after COVID, you know, it's clear you can't provide those basic infection prevention control services if you don't have the basic WaSH services, and those two tools actually align quite well. Where I think, and also to your point around climate, certainly we've also seen countries, especially in the Asia region, really, you know, just zoom ahead with how they can put in more resilience, more storage, backup treatment as part of that wider climate plan. I think where we're still seeing gaps, if for example, is around outbreaks, and in particular cholera. I mean, the WaSHFit tool we first developed and tested in Chad as part of a response to a cholera outbreak that was happening in Chad and Cameroon, right? Now, Chad, there's another outbreak happening, right? So in some ways, it hasn't maybe gotten as much teeth in particular the emergency area as we probably would have hoped by now. But I'll give it to Bruce and Lindsay to add.
That's a really good question. I think one of the key entry points I think we're finding now is healthcare waste management, which seems to really capture people's attention on the health side because, you know, they're kind of like sort out water, and in many ways it's not like another sector's responsibility, but I think it's still a bit kind of simplified like that. You know, like once they're presented with that information, which is pretty, I mean, I don't think anyone has ever not reacted like kind of significantly when they see these low WaSH services. But if you talk about healthcare waste management, I think it's something that we see as a bigger almost entry point to get some of this other water stuff, sanitation, especially hand hygiene as well. So you try to exploit where that health sector and ministries feel their core mandate is, which is obviously IPC, which by the way is still kind of the feeling that it's neglected within. So we're doing something that's neglected, that's, sorry, IPC may be feeling neglected and we're part of a neglected part of IPC, so it kind of goes down the chain a little bit. But yeah, I mean, it's one of many issues, I think, as you all imagine, right? And I think this is one of the things we have to figure out, like, together, is that, you know, there's a lot of power in focusing on the WaSH and waste agenda and being precise, but we also have an opportunity to hit many more important policy decisions and events if we integrate. And that's always the tension, because we lose a little bit, right? Because I think we've been in meetings where the WaSH part is like, you know, half an hour of 4 days at a regional level. And then you start thinking, oh, we could do more on that. But then, you know, if you have a meeting just on WaSH, and, you know, you're not maybe getting as many of the health sector folks as you want. So we've just got to try to maintain that relevance around where there's core responsibilities and expanded.
Thank you, Bruce. Well, we will have more chance for questions here. Thank you, Maggie Montgomery online. We are going to transition to some case studies here. And the first I have, I believe, is Steve Serra, Senior WaSH Advisor at Save the Children. Am I have you first? Or do I have Pat first? Hold on. Let's see. Ah.
Hi everyone, I'm Steve Serra. I'm a WaSH advisor at Save the Children, and I've been working a lot on WaSH and healthcare facilities for the past 10 years or so. I'm here today to present on behalf of colleagues from our project in Laos, which is a Green Climate Fund investment on health system strengthening. To Lindsay's earlier point, this project does not look like a WaSH project. It's a health system strengthening project. That's how we designed it and framed it and sold it. But around half of the activities and half of the budget are actually WaSH activities. So I'm going to dive into how this project is supporting the national priorities on WaSH waste and electricity. And I'm presenting on behalf of an amazing team in Laos, which includes Save the Children, our colleagues at WHO, who are our partner on the project, Ministry of Health officials, and also Healthcare Without Harm, who's serving as a technical consultant for us on this project. Just a brief overview of the project, just to set the context. It's almost a $30 million project. $25 million is coming from the GCF. The rest is raised in co-financing from other donors. It's Green Climate Fund's first ever investment in health. Since then, there have been a few more, but this was the first one that was ever activated, funded. And I mentioned our partners. And just to set the broader context of this project, we have 2 disease areas where we're focusing: dengue fever and diarrhea. Those were the ones that we could justify with the climate science in Laos were set to increase across much of the country due to climate. And we have 4 outcomes. One is focused on strengthening the governance and leadership around climate and health. The second one is on strengthening health information systems. That includes surveillance systems, reporting systems, and also early warning systems. Outcome 3 is service delivery. So we're providing a lot of infrastructure support to upgrade health facility infrastructure, make it more climate resilient. There's also a lot of equipment and materials that are being provided, and then there's a lot of capacity strengthening of the healthcare workforce under that objective. And the 4th objective, which I'm not really going to touch on today, is what's happening in communities to make them more climate resilient as well. The project works in 7 provinces. We selected 25 of the most climate vulnerable districts based on a climate vulnerability assessment that the government of Laos had already done before we designed this project. And as part of the project, we're working in 100 health facilities. Most of them will get upgrades to their infrastructure, but not all of them. And almost all of those facilities are primary care facilities. We're also working in 250 communities who are catchment communities of those facilities. Okay, so now on to the WaSH work. The first thing that we're doing through the project is supporting the National Safe, Clean, Green Hospital Initiative, which we've also expanded to include health centers, the primary care level. And I should note up front that this initiative was born out of work that WHO had supported the government in doing before this project started. So they already had this initiative in place for hospitals. They had also already done a national health adaptation plan. So they had their health priorities set for climate for the country. And they also had done a robust baseline assessment of WaSH, waste and electricity, with WHO support. So every health facility in the country had a baseline assessment of the WaSH and healthcare facility indicators. So we were able to use all of that to then start tackling the problem based on the data that we had on hand. So the first thing we did was we tailored the initiative and guidance and training resources for the Safe, Clean, Green Hospital Initiative to include health centers, because the previous version was only focused on tertiary care. I should also note that this initiative has WaSH-Fit embedded in it, so it's part of the Safe, Clean, Green Hospital Initiative. The second thing we did was we incorporated climate vulnerability and resilience indicators within the national initiative. So now they're tracking a few indicators that are related to WaSH and resilience in health facilities. And then we rolled out trainings so that there is a cadre of master trainers across the country. There's 47 trained so far, I believe, in the project. And they are trained to roll out this initiative nationally. The second thing, or second component of our project that supports the WaSH, waste, and electricity agenda is getting the indicators into the health information system. So we've already been successful in getting all of the WaSH indicators into DHIS2, which is their national health information system. We're working on some of the waste and electricity indicators, but those should be done in a matter of months, I believe. And so health facilities will be required to report on them within the health information system. And then the third thing I wanted to note is some of the upgrades that is happening to the health facility infrastructure to improve quality of care for climate-related diseases. We're doing infrastructure upgrades to, the superstructure, roofs, walls, all of that, as well as all of the WaSH facilities to make sure that they're providing safely managed services. There's also energy upgrades to replace those that were emitting high carbon, and also to provide backup power. For the standard for our project is 72 hours of backup power for all critical health services for each facility. And then with Healthcare Without Harm's help, we're also deploying a tool that Healthcare Without Harm had created for Laos that assesses the carbon footprint of every health facility and the health system. So we're doing these baseline assessments across the 100 health facilities, and based on that baseline assessment and the infrastructure needs assessment, we're creating an upgrade plan that will reduce or avoid additional emissions, as well as make the facility more climate resilient and provide better quality services. That is a brief overview of the WaSH aspects of the project, but there is a lot more to the project, especially on the community side, that I won't cover today. But I wanted to mention that this project is the first of, I think, what will be many Green Climate Fund investments in health and also in WaSH and healthcare facilities. I know that at Save the Children we have 2 active health systems projects, both with large WaSH and healthcare facility components in Laos and in Malawi. We're also designing similar projects in DRC and Nigeria. Those will come in line in 2027 because of how long it takes to get GCF money. And we know there's also another GCF investment in the Cook Islands, and there's likely to be another one approved that UNICEF will lead in Senegal, which is similarly designed. And there's a pipeline of many other health investments, both adaptation and mitigation projects that I'm aware of through the GCF, although Save the Children is not directly involved. And I believe that's it. Thanks.
We've got a few minutes for questions for Steve, if anyone has questions on what he's just presented on Green Climate Fund.
Steve, that's a great presentation. I'm Anne, I'm from UNICEF, and I just wanted to know how you were doing the emissions assessments at the facilities, because I think that's really interesting and, a point of failure for a lot of programs is knowing how to do that and which parts of the system to assess.
Yes. So I'm not a technical expert on that tool. Healthcare Without Harm is much better positioned to speak on this aspect of the program. But what we've done for this program is limit the assessments to the carbon footprint of the health facilities. In Healthcare Without Harm's tool, there are like 4 modules. They assess carbon emissions of equipment and infrastructure, staff time and travel, indirect emissions, and there's a 4th one that I'm forgetting. Our program is only really designed to impact the first one on energy or on infrastructure and equipment. So we're focusing mostly on that module, but we are doing the entire assessment. We're also training provincial and national health officials so that they can use the tool and roll it out nationally. I don't expect that through this project there will be much impact on reducing emissions because the carbon footprint of these health centers is very low. They only typically treat 10 to 20 patients a day, and they're only staffed by 1 full-time nurse, typically. And so it's more of like a step to validate the tool and prepare the government to have a validated tool at tertiary, district, and primary care level that they can roll out nationally. I think in the future they'll be focusing much more on the hospital, district hospital, and tertiary hospital level for that work.
Can you talk a little bit about how the project is positioning for sustainable financing for O&M of the improvements, since that was, highlighted as one of the biggest barriers in the previous presentation?
You'd almost think I planted that question. Yes, I should have mentioned this in the presentation, but one of the, I think, weaknesses of trying to get WaSH and healthcare facility money through a climate financier is that they don't want to fund things that are like typical development problems. Their activities and their investments have to be climate centric. So while we tried to include a large component of work on O&M and supporting service providers, it did not make it into the final design. So that's a weakness, I think, of our program, as well as some of the more WaSH-specific strategies and policies that we would have liked to work on, I think don't completely align with what GCF was interested in funding. We are looking for more investments throughout the course of the project, but so far haven't found any complementary ones. Through our health facility infrastructure assessments, we also found that about 10% of the health facilities we looked at were structurally unsafe and had to be demolished and rebuilt. So we've tried to find funding to support the government to do that work as well, and we've had some success there.
Steve, when you say that you had partners, you had co-financing for this,
Yeah.
was the co-financing all in line with the climate resilient goals? Like it was all in, it was not things that you could have added on O&M and things like that?
Yeah, so that is possible. You could do it during the design and include it in the formal agreement that you sign with GCF, in which case you have to report on all of those co-investments, and they have to be linked to climate outcomes. But you can also add what they call parallel, GCF calls it parallel financing afterwards. That's not reportable to GCF, but it's like parallel work that you're doing. And we've found success in trying both. Yeah.
Super helpful. Well, please thank Steve for his great contributions here. Next up, we have Adam Drillette, Senior WaSH Advisor for PATH, who's going to talk to us about work happening in Ghana, Uganda, and Ethiopia.
Great, thanks, and good morning, good evening, good afternoon, wherever you're calling in from or here in person. It's great to see everyone's smiling faces. I'm Adam Drolet. Let's see, make sure I can get this. Yep. And I'm going to be talking about strengthening IPC, infection prevention control, in Ghana, Uganda, and Ethiopia health centers. And this is really kind of a retrospective lessons learned look using a systems-based approach for this work. And so where I want to start from, again, this is a story that's roughly 10 years long that starts with the voices of front healthcare workers, the voices of them, transitions to then a product innovation and technology innovation program, and eventually evolves into a systems-based approach for improving WaSH and healthcare facility work. And this really, with the theme of the event today, focuses on how can the voices of healthcare workers, their voices, their needs, input and provide a critical input into the 8 practical steps to improving WaSH services in healthcare facilities. And so in 2016, we heard a lot of these I wish statements around environmental cleaning, around IPC, specifically around chlorine. I wish we didn't have to ask patients to bring in their own chlorine for deliveries, for surgeries, meaning that there is a gap in chlorine availability. Healthcare workers noticed that there's an issue with the effectiveness and the quality of chlorine, that it didn't reduce smells, that it didn't address bodily fluids, and that it would rust equipment. And so there's, again, an issue around quality. Getting the right dilution of chlorine based on whether it's granules, liquid, or powdered, or tablets was an issue that we heard from healthcare workers. And the availability of existing chlorine generators was scant, again, roughly 10 years ago. And a lot of these I wish statements, there was data behind them. So doing some formative research, we found that in fact, healthcare facilities in Ghana and Uganda did face roughly 1 to 2 months of chlorine stockouts per year. And you can see the range, anywhere from 11 days to 132 days in a healthcare facility. So you can imagine what effect that has on patient outcomes. In terms of quality, we've done testing of chlorine that facilities are actively using, and you can see anywhere from 36 to 83% of samples were degraded. Again, that's before diluting, so you can imagine the effect on hospital-acquired infections, transmission of pathogens. In terms of dilution, we observed observational data that showed just challenges with getting to that 0.5% for dilution based on the type of chlorine that was available. And again, doing a market assessment, we found that most devices were not user-friendly, were capital intensive, CapEx intensive, and had intensive monitoring requirements and supply chain requirements. And so again, this program really was started with user-based assessments, which led to technical product profiles and design requirements for chlorine generators. And after several iterations, 14 different countries where we tested devices in over 14 different countries, we eventually ended up working with Aqua Research on the Stream device that we then used for introduction primarily in Ghana and Uganda, as well as Ethiopia, using a systems-based approach. In the SDG 6 Global Accelerator Framework was the framework that we used to design how we were going to approach introduction in these countries. And so transitioning to just a couple lessons learned, again, from that systems-based approach, this really speaks to what Jane mentioned yesterday. Investing in relationships was the key that unlocked all of this, and that's investing in these relationships at the start. And what does that mean in practice? It was having those monthly conversations of what is the evidence that would be needed by the government to have confidence to move this innovation forward. So co-design and evaluations. What's the regulatory roadmap? What's the policy roadmap in order to get this integrated into the health system? Laying all these things out eventually led to the Ministry of Health's approval of this device in June 2023 for the public health system. In Ghana, the Ghana Health Service issued a procurement for 400 of these devices after several years of advocacy in June of last year, and is currently installing the first 200 of these in those countries. In Ethiopia, with the recent conflicts, we were able to continue work because of the support, because of the confidence of the government, the Ministry of Health, and the Mahara Regional Health Directorate in those countries, or in Ethiopia. In terms of what helped drive some of these policy approvals and decisions, there's really two sides. One is on the financing side, and one is on the health impact side. So on the financing side, we were able to really help drive what are the financial projections and costing analyses. What would this take for a government to adopt and accept and begin budgeting for the use of this device in health systems? And so we did a costing analysis to show where within the health system, so for example, district hospitals are where you begin to see the break-even point, and what that is per year and over 5 years. And then taking kind of a macro look, when you begin to look at the entire country, if all district hospitals were to accept this device, what would it cost over 5 years, and what's the potential cost savings? And you can see anywhere from $250,000 to roughly $500,000. And that takes into account CapEx, OpEx, training, supply chains, those type of things, compared to the existing costs that facilities are paying for chlorine. So a clear financial incentive there. On the health side, where we saw was a strong potential to address those I wish statements, the statements, the evidence that showed that there were issues around chlorine gaps in supply chain. And so we saw that the device helped to reduce stockouts down to 0 in the facilities in which we worked. It increased the volume of chlorine that was available. Again, the devices were provided with consumables, salt and water, and facilities could produce as much as they want. So it was interesting to see how much facilities would actually produce, and we saw an increase in roughly half of the facilities by a significant amount. We also saw the issue of elimination of the dilution requirement. So the device produces a 0.5%, and that was a huge headache for healthcare workers that this device addressed. We also ran a couple of cost effectiveness analyses looking at the potential reduction on HAIs, on DALIs, again, based on 3 assumptions: the effectiveness of IPC practices, the availability of chlorine, and then the quality of chlorine. And initial projections show a significant potential health impact by having available quality chlorine on site for IPC services. You can see those numbers there. One last point, there's a poster that we have tomorrow, but we did a environmental sampling survey to show is there any difference between using the stream chlorine versus commercial chlorine, and you can see a slight improvement in terms of cleanliness levels measured by ATP of stream chlorine facilities and surfaces compared to commercial. It also helped flag that there were facilities using ABHR for environmental cleaning because there was no chlorine, and using soapy water. So again, it's just one of those flags that of what was occurring. And so finally, for sustainability, I think going to one of these questions, in order for this device and this innovation to continue its longevity beyond this project, there was a significant requirement in order to have operators and maintenance and repair services have the capacity to continue using, repairing, maintaining devices. By installing these devices and accompanying, the Ministry of Health accompanied us on all monitoring visits, they began to see certain gaps in IPC capacities that were needed. And that turned into using this as an entry point for launching in-service training events led by the Ministry of Health on those IPC gaps, those soft skills in the facilities in which they saw and they visited. And then on the maintenance and repair, we were able to train biomeds in each of those 3 countries and develop a network of capacity sharing using WhatsApp groups and applying the materials on a digital training platform in Ghana, which Fred Tusabe, a UNC student here, helped develop in Ghana. And so the maintenance repair, they're distributors in these countries, they're now trained biomeds. So when PATH is now out of the project, out of the vision, these countries now have the technical capacity in terms of maintenance and repair and in the healthcare facilities to continue using them. So again, bringing this back to the 8 practical steps, we touched on a lot of these steps during this process. But again, I do want to bring it back to as countries move ahead with implementing and advancing on these various stages, that the voices and needs of healthcare workers continue to remain a core concept in those activities and progress. And so with that, I'll end there. Actually, I will go back and say, just this quote was from a nurse in Western Uganda, and the stream has improved the availability of GEEK or chlorine, which makes it possible to implement infection prevention control practices more effectively, especially in surgical theaters and maternity. And she was one of the ones that flagged that it was just heartbreaking to have to ask patients to bring in chlorine to deliver your own baby. So with that, I want to thank our government partners. Again, this investing in relationships would never happen without their support, and for the steadfast support of the Hilton Foundation, Conrad and Hilton Foundation. Thanks very much.
Thank you, Adam. Do we have any questions for Adam on the work that they've done across Africa with the chlorine generation? Yeah.
I can just speak up unless you need to.
They can't hear you online if you don't use the mic, sorry.
Yeah, I was just curious. We're good? Yeah, just curious, the chlorine generation, using those type of methods, nothing new. What makes that one, the size of it seems pretty small. Is it the expectation that it will do all the environmental cleaning needs for the hospital, or is it just particularly for the maternity wards, the operating theaters?
Yeah, good question. We didn't have a slide up here, but when you start to look at the chlorine demand across district hospitals, the demand varies quite a bit. When you look at district hospitals, health centers, again, the demand varies. So in some cases, the capacity of the unit can address 1 district hospital. Sometimes you need 2 for a district hospital. Where we were seeing in terms of that break-even analysis, district hospitals really are the prime location, but we're, based on the Ghana Health Services initiative of doing these networks of practice, essentially combining health centers and health posts to share resources. there you can see where you can begin aggregating demand, and it makes then financial sense that break even starts to happen when you further decentralize production of chlorine to health centers and then distribute that among health posts within kind of isolated rural areas. And again, this comes back to what's the value add of this device. It's where that supply chain begins to fail and being able to produce on site. That's where this begins to have those advantages. So to your point, it's a very vague answer. It varies because there is big variation. Part of that variation may be because of supply chain, maybe because of IPC practices that are happening, maybe because of availability of chlorine. There are a multitude of issues. But what we did begin to see is when you start offering the ability to produce on site, that demand and production does increase. And that's for routine practices. We did see in several contexts, Kenya, Uganda, Ethiopia, that as cholera outbreaks happen, as Ebola outbreaks happen, the facilities that were closest located to those areas were asked to produce chlorine immediately on site and begin using that chlorine to begin address the response efforts.
Yeah, thanks, Adam. I don't know whether this question is going to you or Stephen, but Stephen mentioned that they will be implementing a project that will be looking at environmental cleaning in healthcare facilities. So looking at this low-cost kind of intervention, do you think maybe Save the Children will have to leverage that? Because I see it's something that can be sustainable.
I'm going to give that to Save the Children.
Yeah, I mean, we've tried in the past to work with PATH to roll out this technology to other countries. I think we even put in a concept note once to do it in Nigeria. The projects that Save the Children is designing for GCF now in Nigeria and DRC are in their design workshop now. And as I said, it's a broader health systems approach. So the government gets to select, geographically where the work will take place and on what components of the health system strengthening framework they'll focus. But I expect that there will be a large WaSH component given their climate and health profiles in that country. So I think there may be room for technologies like this one to be used, especially because in those countries, what I'm hearing from those design discussions is that they're very concerned about emerging diseases and continued outbreaks. So I think it would be definitely relevant.
Great, thanks. All right, we've got a question back here.
Thank you very much. It's very interesting to realize that there is something good in my country and I just can't find it. So, yeah. This is sounding so new to me, and I've been doing WaSH in healthcare facility for a very long time. So how can we access this? How can we access this machine, this innovation? Because like you're talking about district hospitals, there are districts that don't even have hospitals, they have health center fours, and their problems are more pregnant. Like they have a wish of, I wish I didn't have to tell a pregnant mother to come with water for delivery. So if we could solve the puzzle of the chlorine, I don't know whether it's in your powers to drive this to scale, or maybe how could we work together to scale this?
It's a good question. In Ghana, it really is the Ghana Health Services the one driving this now. They're the ones that are procuring, they're budgeting for the operations and maintenance, for training, for supplies. In Uganda, really, the Ministry of Health, the Clinical Services Department, Dr. Ronnie is the one that I was corrected late last year, and we were saying this is a joint PATH and MOH project, and he said, no, this is a MOH project that is supported by PATH. And so that shows that leadership, that ownership by the Ministry of Health. So that would be your point of contact. The manufacturer is here as well, and another good point of contact.
Fantastic. Great to see there's demand. Thank you very much, Adam, for that presentation. We have one more, and we're going to, again, use a little bit of magic here. Oops, I'm going to pause it for a second. We've got a presentation from Abubakar Balo, who is coming in virtually recorded from West Africa, where he'll share examples of work that's happening with Terre des Hommes. So it's one of these, if I hit the slide, it'll start. So let's just jump right in.
Hello, everyone. I am Abubakar Balo, WaSH advisor for Terre des Hommes and the Swiss Water and Sanitation Consortium in Africa. We are not physically present this year, but it's a great pleasure for us to participate online in this important event. The Swiss Water and Sanitation Consortium supports the efforts of a dozen countries in Africa and Asia in implementing the 8 practical steps to achieve universal access to quality care as defined by the WHO and UNICEF. My presentation focuses on our experiences in Mali and Benin. My English is not very clear, so thank you for your attention. The Swiss Water and Sanitation Consortium works with a holistic vision of strengthening the health system through all 8 practical measures with an emphasis on WaSH fits. In the countries where we operate, our strategy is to work in synergy with WHO, UNICEF, and other partners to support health authorities and in implementing the 8 practical steps through WaSH task forces. The WHO and UNICEF report show gradual progress on the 8 practical steps in both Mali and Benin, despite challenges on certain practical steps, as you can see on these figures here. In Mali, the establishment of a WaSH IPC task force under the leadership of the Ministry of Health with the support of partners including WHO, UNICEF, WaterAid, World Vision, RC WaSH, Terre des Hommes, etc., has been instrumental in obtaining political commitments for the development of a roadmap, define and update WaSH IPC standards, contextualize and scale up the WaSH fit approach, and align the WaSH indicators on the health information system with the GMP indicators, and also gradually capitalizing on experiences with WaSH fits. The Swiss Water and Sanitation Consortium, with technical support from UNC, has developed a tool for assessing WaSH cost in healthcare facility and schools also. The tool has been successfully piloted in Nepal and is currently being rolled out in Mali. The tool enables supports advocacy with evidence so that decision makers prioritize WaSH in health, engage stakeholders, and support accountability, and help WaSH committees develop WaSH improvement plans with realistic cost that facilitate realistic planning and decision making. In Mali's Ségou region, with the support of Terre des Hommes, 5 WaSH fit committees organized meeting to engage local decision makers using WaSH fit data. Women cleaners and people with disabilities served as messengers. This led local governments to prioritize WaSH needs in their budget planning. Thanks to the advocacy of the society, civil society, supported by the consortium, this experience has served as evidence and contributed to making WaSH fit as an accountability tool in the National WaSH Strategic Plan for health care facilities in Mali. In Benin, progress is underway with a health system policy reform launched by the government in 2021. This has encouraged the piloting of WaSH fit in 6 healthcare facilities from 2021 with the support of Helvetas. Today, scaling up is underway in 214 healthcare facilities with the support of UNICEF, Helvetas, and other partners. In Benin, the National Direction of Hygiene and Community Health carried out a visit this year to monitor the implementation of WaSH in 8 out of 12 departments. It then organized a data review workshop with the departmental services. WaSH data is used by the Kandi Health Zone to respond efficiently to the needs of the 15 healthcare facilities. I recorded my presentation from Benin, and I was really delighted to see the progress being made. I was there to support Helvetas projects. So thank you very much.
And thank you to Abubakar. He recorded this mid-travels and sent this to us Sunday night. So much appreciate him coming in remotely for this. And exciting to see WaSH being used both as a monitoring and accountability tool. John Brogan, are you there? If you want to, if there's any questions or any comments you want to make on this, if you can hear me.
Yes, I can. Hey, everyone. Can you hear me, Lindsay?
Yes, if you want to make any comments, then I'll open the floor to any questions on this presentation for you.
Okay, sure. No, it's just, you know, Abubakar couldn't be with us today directly, so he asked me to step in. And I think what we've been seeing, especially in Benin, has been very careful and deliberate steps at introducing the WaSH tool at the national level, but starting small. So it's accompanying the pilots that Abubakar mentioned, that were supported by UNICEF and Helvetas at the regional level and the local level to understand what is the tool, what are the 5 steps, how it fits into their process of monitoring and supervision, supportive supervision that happens. They have, you know, called meetings to look at the indicators, to contextualize the indicators for the health system in Benin. And they've had their own internal meetings on the tool and on the progress that we hear about on the sidelines. So what's exciting to see is that things are moving within the health system for WaSH. And there's not a lot that we have to do to really push that along as temporary facilitators like UNICEF and Helvetas. In one of the meetings, they decided to monitor. So, you know, they allocated their own resources to go and to see in 8 departments, I believe, or 12 departments, what's happening in these healthcare facilities as a result of WaSH. And then Abubakar mentioned this story that came out of Kandi, where the local head of the health authority there decided to look at all the WaSH data and see how he could make grouped purchases of similar equipment and consumables which were needed based on trends that they were seeing as coming up as deficient in the WaSH assessments. So it's local stories like that which are exciting. Also, I think one scoop that Adis and Abubakar mentioned to me just before this meeting was that the Ministry of Health has a department for hygiene and sanitation, and they've got WaSH on Kobo Collect. They've got a Kobo account. They're starting to launch and train the different WaSH teams to at least provide the data that they're using in the assessments, so they can also take a look at what's happening in real time. This has not yet begun, but it's starting to happen. So exciting to see what's going on in Benin. And from Mali, I think Abu summed it up really well. There's been a lot of great things going on in Mali for a long time. So I think I'll leave it there. Thank you very much, Lindsay.
Thanks so much. And that is, apologies, that is John Brogan, Senior Advisor for Helvetas and a colleague of Abubakar. So do you have any questions here on the presentations from Terezom for John who can respond to? Oh, 2 questions, all right. John, we've got 2 questions coming in for you. The first from Darcy and then I think from Jan.
Sorry, not actually a question, but John asked me to plug the costing tool that Abubakar mentioned in his presentation. It's being rolled out across a number of partners in the Wastewater and Sanitation Consortium for a variety of applications. You saw it being used to help cost WaSH fit plans. It's been used by teams for local level advocacy to present budgets to local governments to actually secure increased financing for operations and maintenance, as well as being used to inform national costed roadmaps. It is widely available. I would love to share it with anyone and everyone. It's available in English and French. And we also have a version for schools as well. So if you are interested in doing costing and using this resource, I'll stick around after the session. Feel free to come find me. Thanks.
Thank you very much. My name is Jane Navinyad. I work with IRC in Uganda. I have a question for John, especially related to the sustainability plans and how these have been embedded in government and in local government. And then to Adam, just to share with you that I was present at the launch of the chlorinators by the Ministry of Health. I have visited Rotete Health Center 3, now it's going to 4, and I've seen the chlorinators in action when PATH was still working with them. I've visited the same healthcare facility after PATH stopped working with them, and the chlorinator is still working. And what I learned from the cleaners and janitors, they're very excited about it. The health center is very clean because they know they don't have to struggle to get, what to use. They know how to manage the machine. They know how to repair it. They take care of it. And it's the janitors and cleaners that talk about it, not even the in charge. So I thought that was very, very interesting, that the lower cadre that we normally don't even remember that they are there, and yet they are the ones responsible for the cleanliness of these healthcare facilities, know and use their machine. They call it their machine, our machine, and it is working. So my sister from Uganda, we can link up. That is, Rutete is in our district where we operate, and I know that there are other chlorinators in other facilities in a number of districts. And as Adam said, it's the Ministry of Health. It's the one in charge, it's responsible, it is leading, it knows how to work around all these things, and they look at PATH as a facilitator. Thank you.
Thank you, Jane, for that testimony. That's fantastic. John, were you able to respond on the sustainability plans question?
Sure, thank you. Thank you, Jane, for the question. It's nice to be in touch. In West Africa, we've collaborated quite a bit with IRC, WaSH, in Mali, especially with Dr. Afu Bengali, and looking at how WaSH Fit is fitting into the building blocks for WaSH system strengthening as well. So one thing I could share out of Benin is that every year the district health authorities are needing to submit an annual development plan, which is something that gets approved at the national level and decides what kind of equipment and upgrades that they can make and consumable purchases. When we did a capitalization of experience on a pilot of 6 healthcare facilities for WaSH Fit, in the presence of the district health authorities, they said, every year we're wondering, what are we going to put in this plan? And this WaSH Fit improvement plan is very useful for us because we can have at a glance and we can aggregate and understand what are the needs that we can then integrate into our annual development plan that gets funded by the national level. So for us, it was a great starting point to see how WaSH Fit is not just it's not just a tool which is promoted by some local actors or development partners. It's really something that could integrate within the health system.
Fantastic. Thank you so much, John. And thank you to all 3 of our case studies. Give a round of applause here. We have organized so many side events on WaSH and healthcare facilities over the last 10 years, many of which at UNC, and it's just really nice to see progress. It's been a tough year for everyone, and so it literally makes my heart sing that there's so much happening. So thank you all for sharing. I'm sure all of you have your own stories and would love to speak to you all after to hear about the great work that's happening. I'm going to call up Ryan Crunk here to talk about community practice as we close up and how you all can stay engaged and share your own work and be involved.
Thanks, Lindsay, and thanks everyone for coming and everyone online. I just want to plug the WaSH and Healthcare Facilities Community of Practice. If you are not part of our group, we'd love for you to join. The Community of Practice has been around since 2021. It was launched at Emory, and now UNC is the secretariat for it. And yeah, basically our sort of goals of this group are to connect partners around the world. It's a platform to swap ideas. We host a monthly webinar, and we're launching some other engagement opportunities. And our main goal is to help people like you take action on a lot of the best practices and evidence that we learn in sessions like this. So feel free. We have a long-running newsletter. We just launched a LinkedIn group. We're hoping for some new types of engagement through LinkedIn, since that seems to be where everyone is congregating these days. And as Lindsay alluded to, I do want to plug our other side events this week. We'll be in this room today and tomorrow. This afternoon, we've got a great session on faith-based engagement in Washington healthcare facilities led by our colleagues at CRS and many other partners. Tomorrow morning, we have, with the World Bank, a session on management models, sustainable management models in Washington healthcare facilities. So we're going to hear a lot of really exciting case studies from around the world on how to do sustainable Washington healthcare facilities. And then on Wednesday afternoon, we've got a really great sort of late-breaking session on what's next in Washington healthcare facilities, which promises to be excellent. If you liked Lindsay's Zoom magic, I heard Bruce acquired a crystal ball and dragged it all the way from Geneva, and he and Anne and others will be helping us look into the future on what's next for Washington healthcare facilities. So it promises to be a great session. I think that's all I had, so thanks again, Lindsay.
Thank you. Please join the groups, join the newsletters. Also, washinhcf.org. If you haven't checked it out, please go look. All of the resources, the reports I mentioned today, they're all archived there. There are tons of country resources. I am happy to share any resources you all have on there. Send them to me. We'll get them online. But it's a fantastic place to hear what is happening there. Last but never least, I'd like to invite up Ann Thomas, Senior Advisor for WaSH and the lead of Washington Healthcare Facilities, this portfolio at UNICEF.
Thanks so much, Lindsay, and thanks everyone. I think it's been such a great session. As Maggie started out, WaSHFit started as a practical tool to help map out vulnerabilities in healthcare facilities, and it's just so amazing to see how it's evolved into this tool that is now linking healthcare facilities to climate resilience, that's being used to strengthen systems at country levels and linking sort of seamlessly with national systems. So I think there's been a huge evolution, and the practicality of the tool is in the power that it has, that it's generating local data to inform local decisions and then trickling up to policy decisions. I think it's also very exciting that it's being linked to climate finance. And I don't think it's a coincidence now. There's a lot of momentum in the sector being generated through high-level advocacy. But the issue of financing has plagued the sector. So I think using the tool also to generate more and more secure financing for the sector is going to be really an exciting place for us to keep track of. So I'm not going to say much on next steps because we do, as Ryan and Lindsay said, we do have a session tomorrow. So I think your next step is to come to the session tomorrow and hear what's next for Washington Healthcare Facilities. So thanks so much, everyone.
Chad? I have a meeting from 12 to 12:30, but then I'm free. I don't remember what time lunch.
It starts.
I'm having these. Make sure that works.
Look at that.
Thanks, nice one.